Good afternoon. This is Bryson. You are listening to GenRX Radio on 90.7 WCLH, Wilkes-Barre, Scranton, Hazleton. Keep it locked.
My name is Jamie, and with us we have Dr. Thomas Franco, an associate professor of pharmacy practice here at Wilkes University Nesbitt School of Pharmacy.
I'm always happy to be here and happy to be back for yet another week.
We will always have a licensed pharmacist faculty member with us on our show to ensure accurate information goes out to you. We are here to bring you weekly topics centered around the opioid crisis, proper medication use, and disposal. And not just my community, your community, or our listeners' community, but it is all of our communities. Be sure to tune in every Wednesday afternoon from 1 to 1:30 p.m. right here on 90.7 WCLH for new topics and discussions.
So we wanted to give a little recap of last week. So last week, Bryce and I introduced ourselves and talked a little bit about our club, Operation Substance Use Disorder, and its mission to educate about and prevent the misuse of substances such as drugs and alcohol. We also discussed the latest data regarding fentanyl deaths in the past year and briefly mentioned how COVID-19 and other factors have impacted the numbers.
Like we said last week, that there's over 100,000 people that died from a drug-related problem in between April 2020 and April 2021, which is just crazy. And that fentanyl, and it's not prescription fentanyl. It's not like the patches that you could get at your pharmacy or that a loved one you know might be using. This is non-prescription fentanyl, which is, we'll say that a nicer way of saying illicit fentanyl. And just the fentanyl deaths in that 12-month period was more than all of the deaths in 2016 associated with drugs. So it's not so much a prescription issue anymore, but a tainted supply issue. And that's something that it's going to take a lot of effort to try to correct.
Yeah, definitely. And that's something we actually want to get into this week and dive deeper into. And I know everyone is tired of hearing about it, but this data shows just how much COVID negatively impacted people with substance use disorder. I think everyone, including myself, is ready to move on from COVID and hopes it will go away. But I think we also need to learn from what happened so we could be more prepared if there's another time where we have to go into lockdown.
Yeah, I think if we go in, this is just my opinion, if we go into a lockdown, it's going to be insane. Like something horrible would have to happen. Mm-hmm. I know that recently the administration came out and said with this new Omicron variant that we're just going to pay attention to it, we're going to track it, but we don't foresee a lockdown happening. You know, that said, COVID-associated lockdowns certainly played a role in these numbers. We saw that people were using drugs alone because they were not able to it's not like they were going out and hanging out with friends, but people were sometimes using in a Starbucks or using in a McDonald's because they know that somebody will find them. Well, if you're stuck inside your house, there's going to be some situations. There's also been increased levels of depression, anxiety, and a lot of chemical coping because people lost their jobs, they lost sources of income, they lost loved ones. There's been a lot of negativity around treatment options for COVID, in particular the vaccine. So maybe this is somebody who was vaccine hesitant and got shamed by loved ones because they did not get the vaccine, which is, not cool. You should not shame people. And they turned to using because addiction's fueled by shame. And then the other side of it was treatment centers closed down because of financial issues. So we had isolation, increased depression, increased chemical coping. There wasn't enough treatment the way it was, and what was out there closed. So this was almost a no-brainer that this was unfortunately going to happen. And I think that's what a lot of people missed was that when lockdowns occurred, A, did it really do anything? I mean, look where we are now. But B, look at the ripple effect that had. And I feel that some of our public health people want to avoid a similar ripple effect in the future.
Yeah, we talked a lot about Al-Anon meetings and NA and AA meetings closing, and I think that was a big impact too because a lot of people rely on that for a support system.
Yeah, they do, and that's virtual options were made available
for people who had a computer or the means to attend.
And you think, it's 2021, everybody's got computers now. Not really. I know people who don't have a computer or a smartphone, but we also need to remember that people lost their jobs. They lost their sources of income.
Right.
And if it meant I can pay my gas bill, which I don't know if you've gotten gas bills recently, but we're told that all the prices in Pennsylvania are like going to skyrocket this year. I'm really excited about that. But if my options are maintain my Wi-Fi or maintain my heat, I'm going to pick my heat and just, I don't know, read a book. So there's the potential that people lost internet services too. And it's not like you're just going to walk down to a Starbucks or to a Dunkin' and hop on the Wi-Fi because they're locked in their house. It's isolation time.
Yeah, those are all great points. I've seen some experts even say that mental health is going to be the second epidemic after COVID is all said and done. There's going to be a ripple effect that lasts for years afterwards with mental health. And I think that's just a reminder that we should continually check up on family and friends and just see how they're doing.
You know, there was a mental health epidemic well before COVID. We just didn't want to talk about it because up until even 5 years ago, mental health was taboo. You don't talk about it because it was considered a sign of weakness. It was considered you're not strong. Get over it. Or another good one, if you're somebody who was financially well off and you had a nice house, you had a good job and all that. Well, why are you sad? Why are you upset?
Right.
You're at least you're not like, there are people out there way less off than you. But that diminishes somebody's feelings, and their feelings are just as valid just because the situation is different. COVID just amplified all of this. COVID demonstrated that there was a massive anxiety and depression issue, especially amongst younger people in this country. And why? I have no idea. But it's absolutely going to be here well after once COVID becomes endemic. It's this COVID zero thing is not going to happen. So once it becomes endemic, 100%. I think we're getting better at recognizing mental health as legitimate, but we need to get socially to a point where it's accepted at the same level as diabetes and heart disease and asthma currently are.
Mm-hmm. Yeah, I think these are all great points. And not to hate on DSM-5, but I think also there needs to be a change in prescribing trends. Like, generally, I think it's a little too easy to get prescribed, like, antidepressants or anti-anxiety. And I think, we should focus more on therapy and counseling.
Therapy, so talk therapy or going to a counselor or a psychologist is the number one thing we recommend for every mental health condition. When you look at the evidence for any mental health drug, they all say best when used in combination with counseling.
Right.
So we need to, it's not so much a referral. We need to increase referral rates. What we need to do is try to find ways to encourage providers to go into that kind of field, because it's not the glamorous field of healthcare as, say, being a cardiologist or an orthopedic would happen to be. So we need to encourage people to go into it. We need to encourage insurance to pay for it on an ongoing basis. It's not like, okay, you went for 2 weeks and now your insurance kicked out. We need to make sure that there's adequate coverage for it. Even locally, there's not a lot of options. There's maybe like 3, 4. So we need to get more access to care. The prescribing, that's just more education on how the medications work. There are oceans of mental health medications that are out there, but not too many people understand, well, what's the real difference between this one and this one? So that's where having a pharmacist on board can help you, because pharmacists know the differences between all these medications and which ones may be best based upon how a patient is presenting.
Definitely.
Yeah, so we want to talk a little bit about the fentanyl numbers again. So fentanyl, we said before, was responsible for about 2/3 of the opioid deaths in the past year. And fentanyl is a synthetic opioid, meaning it is man-made and much more potent than morphine. It is commonly used as a prescription to treat severe pain, but as Dr. Franco said, illicitly, it can be mixed with other illegal drugs such as heroin or cocaine because it is a cheap additive that still creates a euphoric effect. Dr. Franco, could you speak a little bit more about this and why you think it might have led to so many opioid deaths?
I appreciate the why you think.
Yeah.
There's not like I'm not sitting here with a crystal ball to be able to figure it out. So why fentanyl? Well, Fentanyl is dirt cheap to make. When you look at something like heroin, heroin requires a lot of raw material. It requires fields upon fields of poppy seeds. And it's also becoming more and more difficult to make more and more pure heroin. This isn't being made in a lab. It's being made in a rather clandestine kind of way. And it's also become more difficult to transport it. You've seen dogs at the airport. You've seen, agents at the ports trying to find it, because that's how most of the drugs get in the country. It's not, smuggled in the way the media might make you think. It's coming in cargo ships and airplanes. That's where we're at with heroin. So here comes fentanyl. Fentanyl's completely man-made. It requires very little raw material. It's potent. Now, potent doesn't mean powerful. It's not more efficacious than heroin. It's not going to work better. It just means that a little bit of it goes a long way. That's all potency means. And I think that's a big thing that as pharmacists, we need to make sure we educate patients that just because it's potent doesn't mean it's going to be better for you. The other thing about fentanyl that's interesting is that the molecular structure of fentanyl is very basic, especially compared to morphine or heroin, which are rather complicated. And it's so basic that anyone with a bachelor's of chemistry can pretty much figure out how to adulterate that molecule. And that's how we get all these different derivatives of fentanyl that are out there. So it's easier to make, it's easier to transport, it's a little bit goes a long way, it's easy to consistently change it. So of course it was going to lead to everything. It's what would I rather do? If I'm in this business, I'm going to go after the cheapest product and sell it at a higher rate. That's why fentanyl has come into play.
Yeah, those were just some great points, and just a point like I saw when me and Jamie were researching it, but fentanyl is like 30 to 50 times more powerful than heroin, and I thought that was just a crazy stat because everyone knows like how much death heroin has caused and just how easy it is to overdose on. So I can't imagine what fentanyl is like. And I think the article we were looking at showed a picture of like a couple sprinkles of like salt or something on a spoon, and like that was enough to overdose. And I think that's just crazy to think about too. And me and Jamie were also talking about the possibility of fentanyl testing strips and how they could potentially help someone detect if their drugs were laced with fentanyl. And fentanyl testing strips allow someone to dissolve a small amount of drug in water and then use the test strip to determine if it was laced or not. However, we found out that these are technically illegal in PA because they're considered drug paraphernalia, which means you could be arrested for having or selling the strips. However, the mayor of Philadelphia did sign an executive order not to arrest people for having these strips. But Dr. Franco, what's your take on these strips and the law in Pennsylvania?
Well, I think with Pennsylvania, if nothing else, the way in which COVID vaccine rolled out demonstrated that there's 66 counties, and then there's Philadelphia. Philly kind of does its own thing, and I'm not sure how they do it, but it's good that they do. Fentanyl testing strip basically is like a litmus test, or no different than someone putting a diabetes strip against their finger to check their blood sugar. Yeah, it's noted as illegal because it's considered drug paraphernalia, and that's just silly. When it's considered part of treatment, and when we look at locations where these strips are legal, because there are other states where they are, we see that they do act. There's evidence to show that they do act as a deterrent. I was talking with a colleague in Rhode Island, and he said, well, fentanyl up here is just a nightmare. Now, Rhode Island has oceans of harm reduction measures in place, in effect. Call it a benefit of being a small state. And he said people are using heroin, turns out it's all fentanyl. They're using cocaine, turns out it's all fentanyl. They're taking pills, turns out they're fake and they're all fentanyl. So these strips can go to help people realize, oh, this is maybe I shouldn't use this. And remember, if somebody tests this thing and goes, uh-oh, I should not do this, and they maybe go and use, off the street buprenorphine, or they find something else that doesn't test, that's at least showing that their brain is in a position that it's getting ready for recovery, that it knows recovery can happen. Because if they saw that it was fentanyl and go, wow, this is fentanyl, I could die if I use this, and they go, well, I'm going to use it anyway. That's still that addiction shutting down the part of their brain that controls rational thought. But if they go, ooh, I should not do this, and they put it down and they do something else, hopefully that something else is buprenorphine or going to get treatment, that shows that their brain is in a position where recovery can happen because the part of their brain that makes good decisions, that makes rational decisions, is working. And I think that's where people lose sight. They think that recovery is an all or nothing type deal. Recovery is a path of a million steps, and that might be the first step on that person's path.
Yeah, those were some great points. And I just want to touch on buprenorphine quick for those of you who don't know. It's a partial agonist that's used in opioid addiction treatment. And what it does is it binds to the receptors, and when it builds up in your body, it eventually levels off. So it gives them a little bit of feeling of being high, but it won't let them overdose on it.
Yeah, it's not so much a feeling of being high. People don't use buprenorphine. Well, I should just put it this way. People who are in recovery or people who are trying to enter recovery, who are on buprenorphine for purposes of maintaining that recovery, are not seeking euphoria or a high. When you utilize buprenorphine for that purpose, you really don't get that because, as you said, it plateaus off. It just flattens at some point. But what it does is it gives the brain enough of a dopamine push that the craving, which is the true suffering of addiction, is not there. It also does not precipitate respiratory depression, so you don't go into overdose on it. So ultimately what buprenorphine does is it satisfies the brain's need for a specific neurotransmitter while ensuring that the patient maintains a job, takes care of their family, stays out of jail. So buprenorphine really should be viewed no differently than insulin or a blood thinner for people who have AFib. These medicines are used to help supplement something that the body needs in order so the person can be functional. So buprenorphine gets a bad rap, but we can go down a rabbit hole about that another time.
Yeah, I'm sure we'll talk about that a lot more in a
absolutely.
future show.
We will. Several future shows, probably.
So, Dr. Franco, you talked about education with potency and a little bit about buprenorphine. What else can pharmacists do to help our patients?
Honestly, the best thing you can do is, well, first off, if you're a pharmacist, the best thing you could do is get some more education. The amount of education that most people get in pharmacy school on this topic is woefully low. In fact, last year, one of the National Pharmacy Associations put out learning guidelines for all pharmacy students. Big school, little school, like everybody has to know this stuff, they said. And it was quite robust, way more robust than what we're getting now. Because you have pharmacists, you're the most accessible healthcare provider. We have the opportunity to help educate and diminish stigma, to educate about public health, and to act as a coordinator of care rather than a barrier to it. So things like dispensing naloxone, sterile syringes, having information on treatment near your register, those are things that you can do. If you're a patient, talk to your pharmacist because they know all this stuff that we just talked about, and they can help you. And again, most trusted healthcare providers. So we know that patients will trust what pharmacists say, and we encourage them to use them. They're, at least for now, free medical advice. So take advantage of that.
Thank you, Dr. Franco. So we're going to take a quick break. Thank you for listening to Generation RX Radio. Keep it locked on 90.7 WCLH until we return.
Welcome back. You are listening to 90.7 WCLH, Wilkes-Barre, Scranton, Hazleton. For those of you just joining us, you are listening to Gen RX Radio. My name is Bryce, and with us is Dr. Franco and Jamie. Before we move on, let's do a quick recap of our first half of the show.
Yeah, we were just talking about the impact that COVID, more impressively, the COVID situation, more so than the virus itself, had on people and how it led to them coming to over 100,000 people dying, the highest number ever that has happened. And then we talked a little bit about mental health and the need for increasing access to care to mental health, because once COVID becomes endemic, not zero, endemic, we're going to get to a position where all this ongoing mental health, depression, anxiety, chemical coping needs to be addressed.
Definitely. And then current events, this week a federal judge in two Ohio counties, Lake and Trumbull, held Walmart, Walgreens, and CVS accountable for their role in the opioid crisis. They stated that they created a public nuisance which cost each county nearly $1 billion in costs. The three chains disagreed with the jury's decision and plan to appeal their decision. I think this is just a chance for us to talk about that not to use the term, but there might be a few bad apples, but overall, pharmacists are just a great resource and one of the most accessible healthcare workers. And I think they're leading the charge in the fight against opioids. And Dr. Franco, could you just talk a little bit more about what community pharmacists are doing to help combat opioid addiction?
Yeah, there's a lot that community pharmacists are doing right now, and it's not just a Scranton, Wilkes-Barre, Hazleton type thing. This is stuff that pharmacists are doing across the country, and it's from dispensing naloxone to harm reduction efforts, such as giving out sterile needles, to educating people about where treatment facilities in their area are located, to stocking buprenorphine. So many pharmacies are not stocking buprenorphine because they're afraid of either A, people, they're just like, I don't want to deal with this. B, they're afraid that some government, or we'll call it overzealous government agencies like the DEA or other law enforcement will come in and smack them with lawsuits. This actually happened in West Virginia. There was a pharmacy in rural West Virginia that was hit with 2 DEA sanctions for what they felt was over ordering and over dispensing of buprenorphine. And they got taken to court twice. And both times the judge found in favor of the pharmacy because this pharmacy was the only pharmacy in like some ridiculous radius that stocked buprenorphine. So they were the only source for people from various states to go to get help. But the court costs were so high that the pharmacy went out of business. So at the end of the day, that person's now livelihood, because it was an independent, that person's livelihood is gone. And all those patients are now stuck trying to go someplace else. So I'm not trying to say that the DEA or law enforcement is bad, by no means. It's the pendulum has swung in such a direction now from where we were 20 years ago, which was, medical and the medical community was not under the purview so much of law enforcement up until everything happened with Purdue and OxyContin and stuff like that. But now people are terrified of doing this, and guidelines are out there saying, don't give this stuff, don't give this stuff. So there needs to be a middle ground. We may come back to that. I don't know when. But that's the issue that I see a lot of community pharmacists facing is I want to do it, but my hands are tied or I'm afraid to do it.
Yeah, those are some great points. And I could definitely understand, like, from an independent or like a store owner point of view, like how that could be one of your concerns.
Yeah, they put their livelihood on the line to help people, and then they ended up losing it in the end. So that's really, really sad.
Yeah, that is really, really difficult. And just another current event we were talking about before this, New York just opened up a safe injection site. Could you talk about that, Dr. Franco?
Yeah, this is quite a hot off the presses type deal that New York City opened up a safe injection facility. Or I think a better term for it I've heard was comprehensive user engagement site. So this is the type of facility where somebody will go to use some type of drug, but they have healthcare providers there, they have harm reduction tools there, so they have things like naloxone, information on treatment, information on AA, NA, sterile needles. They have all of this stuff there, immunizations for hepatitis. All of that is there, social services. And it's a way to bring treatment to where people are. Instead of having people go to this person and this person and this person and this person, it's a hassle just to do that for heart disease, let alone for a condition that dramatically impacts mental health. And the number one symptom is it pushes people away, so you end up being by yourself. So New York City opens up, I believe they opened it up in East Harlem is where I believe the article said they had it. And this is in stark contrast to federal law. It's against the Controlled Substance Act. And this was actually 2 years ago. the safe injection facilities were found to be legal, and they tried to open one up in Philly, and then the government appealed and won on the appeal that said no, it's actually against it. So the new administration, it has a, we won't look at it if you don't make a mess of this type look. And New York City is just going with it. Now the residents of that community are not happy. They're saying, well, we don't want to bring people who use drugs into our neighborhoods. There are schools and kids near here. We don't want to expose them to that. There's excessive amounts of trash and litter, mainly used needles everywhere. This is going to drive down property values. We plan to sue. This isn't right. So it's contentious. But we do know evidence from this is legal in Canada. So in Vancouver, they have a safe injection site. And there's several in Europe as well, that these actually do help people who might otherwise die if they didn't have access to it. So it is that catch, because yes, there is the social issue of property values and crime maybe and exposing children, and those are valid points. We shouldn't say that they're not. They're very valid points. And there's valid points on the other side too, but I think more discussion needs to be had because there's a clear benefit to people. We just need to see how we can make it work for the community at large.
Yeah, definitely. Like you said, I think these are a good thing. I think with all the resources they have, it might just be that like going to one of these safe injection sites could be getting their foot in the door. It might lead them to going into more comprehensive treatment or going into AA or NA where they could get even more help.
Yeah, the number one issue with people not going to get help is they don't know where to go to get help. So here we have a situation where it's in their community. They can go to it. They're not going to be judged for going to it. And while they're there, all the resources, it's a one-stop shop. All the resources they need are there. And people will say, well, how come this isn't available to people who have diabetes or cancer or heart disease? And my response is, well, that's a good point. But just because they don't have it doesn't mean that this other group should be denied it too. This isn't a, well, if I can't have you, nobody can have you situation. That's how you become a Law and Order episode. What we want here is that, yes, they have it, and that's good. Now get everyone else to replicate it. So, yeah, let's not have this be a, I can't, so you can't. Let's have it a, you have it, let's all get it now too. That's a better way of thinking in this case.
Yeah, I really appreciate you bringing this up too, because at least when I first heard about these sites, I know a lot of people were just saying, oh, they're just a place where people are going to go do drugs, but they're really a resource with lots of people there to help you. They have even the, you said the vaccinations. I think that's all really important. And like Bryce said, it's definitely a way to maybe take a step towards recovery. So I think they're really could be a great resource.
Yep, and with that, I think we're going to wrap it up for this week.
Thank you for listening to Generation RX Radio with Bryce, Jamie, and Dr. Franco. Until next week, keep it locked right here on 90.7 WCLH.